It's Christmas, time of year. Our families by the fire, snuggled up like bunnies in the snow. It's Christmas, Christmas. Little birds are singing like a choir. Winter chill is nipping at your nose. I've been waiting all year for this. Grab your cocoa and we'll reminisce. Oh, how I love when Christmas comes around. It's Christmas, burnt the pie. Who cares, it's still divine. So fine. Give me all the whipped cream you can find. It's Christmas, records on, trim the tree and sing along. Watching Hallmark movies all night long. I've been waiting all year for this. Ugly sweaters I just can't resist. Oh, how I love when Christmas comes around. When it comes around. It's Christmas, candlelight, midnight carols at the church. Singing, let there be peace on earth. I don't need a single gift. There's no present that compares to this. So I just love when Christmas comes. I love when it comes around. Oh, I just love when Christmas comes around. You know I love when Christmas comes around.
They say it's a matter of time, 1,000 days and the sun won't shine before I come back to you. When I'm happy, nothing's going to stop me. I'm making my way home, I'm making my way. For your love I will go far, I wanna be wherever you are. I know I'm coming back for you. Our love is a river long, the best ride in a million wrongs. I know I'm coming back to you. And I'm happy, nothing's going to stop me. I'm making my way home, I'm making my way. I go solo, oh I go solo, I'm making my way.
We're live. I didn't really expect any of you guys to join me, so this is totally uncalled for, right? Okay. Out of the blue, I decided to do this. Today is something special tonight because I'm going to invite you to my own one-person study club. What do I mean by that is some of you are asking, like, at my situation, who does implant for living, who does 10 to 15 implants per day, and been doing like that for over a decade, what kind of courses do I take, right? Do I actually go and take courses like, most of other implant dentists? Well, answer is no. I mean, there are a few courses that I go and take that I feel that I'm going to learn something conceptually advanced or something that can help me implement some of my clinical skills. I do go and search out for those things, but the matter of the fact is I've been doing surgery for a long time, and there isn't really that much of a technique driven courses that I need to take. No, I don't really take that many courses. I do take it, but very, very seldomly. However, what I do is I try to learn concepts. I try to learn different concepts, something that I can add on to my philosophy, and that is what I'm going to share with you tonight. Okay, so some of my favorite time for me to do learning is after I put my kids to bed on the weekend. I'm by myself, enjoying my little coffee, or tonight I'm drinking some tea, and have give myself a private time for about an hour or so, and just read some articles sometimes and look at some of their cases. And sometimes, like tonight, I'm going to watch their presentation. Okay, tonight's presentation is actually one of my a clinician that I really admire, a friend that I've got to know over the social media, Facebook, and the fact of the matter is I've never met him, but I have a tremendous respect for him. We have a mutual respect for one another, and we recognize each other's talent and their surgical philosophy. And he's none other than Professor DS Sohn. Many of you probably know he's a very well-recognized global speaker, presenter, and he is an oral maxillofacial surgeon from Daegu City in South Korea. Right? What's unique about him is typically, people who are professors, who are academic, they're not very clinically strong. they don't get to do that many cases because they're too busy putting cases together and publishing and article and things like that. However, he's different. He's different breed. Professor Sohn, he is quite a what do you call it? A prolific surgeon. He does a lot of implant, at least 1,000 or much more per year, and he's been doing that at that rate for many number of years. So he puts that reality puts him in a very a unique position. He is very academically sound and very strong. He's very legit, but at the same time, he does so many cases so that he refines his surgical approach based on very strong fundamentals. And I'm going to watch one of the presentation. Okay, I haven't watched this one, so we're gonna watch it together. And I'm going to talk about what are the key highlights, and maybe we can learn together. Okay, all right. Let me see right here. So I don't know if you guys can hear it properly.
Hello everyone, I'm Professor DS Sohn at Department of Oral and Maxillofacial Surgery, Catholic University Medical Center of Daegu. I'm very honored to be invited to first international symposium of complication in implant dentistry. Unfortunately, I'm very sorry I cannot meet you personally in this symposium due to COVID-19 crisis. I hope all of you to be safe and to overcome COVID crisis well. Before I start my presentation, I'd like to express my sincere appreciation to Dr. Das, who is Congress Chair. I remember he did a wonderful lecture in last World Cup's meeting held in Netherlands. Thank you very much for inviting me to Iran. And my thanks go to Dr. Ali, Mr. Amin, who is president of DR Tahis, and Mr. Lee, who is president of Vitam Implant, for inviting me to this symposium. Exactly 10 years ago, I was invited to International Implant Symposium held in Tehran. After my lecture and my hands-on course,
so interesting.
surgery,
He was supposed to be physically attending this year in Iran as one of the keynote speaker, but he couldn't go because of the COVID-19. So in some way we're lucky, right? We're lucky because we would not have been able to watch this a video if there was no COVID-19. So it's like a blessing in the disguise, right? I would love to go to Iran. I mean, there's so much rich history.
What I'd like to talk about today is a simplified three-dimensional ridge augmentation using sticky bone and tenting abutments. Atrophic alveolar bone with a large defect is a challenging site to restore with implant-supported restoration due to aesthetic and
So the title of tonight's presentation is a simplified ridge augmentation.
Four biologic principles, which are primary, unclosed, angiogenesis.
This four biological principle is based on the Homley Wang, very renowned professor.
Necessary according to the Homley's publications. Among them, the most critical factor for successful 3D ridge augmentation is space maintenance. How can we maintain volume or bone graft during healing period? This slide shows my old method to maintain grafting materials for three-dimensional ridge augmentation. This is chin bone graft. This is titanium reinforced Gore-Tex method.
Yeah, I remember those days.
Titanium mesh.
There were times that ramus block and chin block, like what he's showing, was the standard. I remember I purchasing a first piezo electric surgical unit for $15,000. That was like 15 years ago. What, 16? More than that. Just so that I can do this.
Can provide solid space maintenance for three-dimensional ridge augmentation. I used to be a big fan of auto Blackburn for three-dimensional ridge augmentation, as shown in this my published publication in 2007. This patient came to me with a complaint of severe tooth mobility of left anterior bridge. So this teeth was extracted and 2 months of teeth healing was allowed. And full thickness flap was elevated to expose for any defect. Take a closer look at the huge three-dimensional defect. Piezo surgery was used to harvest.
I remember when we were teaching these, doing a cadaver course, as you can see. To teach something like this, we had to, do a cadaver courses for our residents. We used to go and borrow the morgue at UBC, anatomy building, and when ordering a fresh cadaver heads.
From chin was grafted on the
It was a lot like a carpentry, measure up, use the piezo or use the drills to cut the edges and crack it open.
This is 1 month healing. Healing was uneventful, but patient complains the mild numbness and moderate facial swelling after surgery.
Numbness is from the chin. Not a damage if you have the nerve, but you get a little bit of woody sensation because of the nerve that innervate the lower incisors. They get severed, right?
This is final restorations. This is before. This is.
He's a good surgeon,
Delivery of final restoration.
I find that Professor Sohn has really good fundamentals.
This is the
a lot of us don't appreciate his post because he's on the Facebook, he just puts few photos and not much explanation. It's like, here, these are my case, and then you figure out yourself kind of deal. But if you understand
there are many,
his thought process, he's a very slick surgeon.
Grafting, as shown on this slide. So secondary donor site is required. The bone desorption is sometimes unpredictable. The wound exposed can cause serious complications. This technique is a very difficult task, and we cannot place the implant at the same time, so the edentulous healing period is delayed.
Yeah.
This slide shows one of the complications.
Absolutely. We used to get this quite a lot.
You can see that
not only that, when we reflect and take the bone out, and we have to put the chin back into the right position, we had to tape them up. Otherwise, you get a witch's chin, or chin dropping. So,
in my colleague's case, he did the harvesting of ramus bone with the high-speed burr, but he cut the artery during osteotomy.
oh goodness.
Severe bleeding happened and reported to me to control these severe complications.
Professor Sohn, he gets a lot of emergency cases here.
And the artery was tied to control bleeding, and a gelatin sponge was packed to control.
People can die from excessive bleeding when you cut an artery like that.
This is 1 day after. He was admitted for 2 days to compensate the blood loss. So I recommend to use piezo surgery when you do osteotomy intraorally to protect the soft tissue or vital organs. This slide shows one of the disadvantages of autogenous black bone.
That's the one surgery that I haven't done for a long time, is a hip graft. Last hip graft surgery that I've done was, 8 years ago.
After
I believe. Yeah.
4 to 6 months of bone grafting.
Anterior
Iliac
crest.
shows you about 50% of bone resorption over time. This is my case is using Lemur's black bone. The piezo surgery was used to harvest Lemur's monocortical black bone, and for vertical augmentation,
That's
black
the
bone was
amazing thing is that a block
grafted on the left
chin
side
or ramus
and
block
sides
graft,
of
we haven't done it for
was
so
at the
long,
same time, collagen barrier
and
was carved over the
it's
bone
making a
graft.
comeback, isn't it? Like a curry technique, right?
Implant was placed at her dentist. After 5 years in function, she came back to me for a follow-up. You can see that the complete loss of the lemur's bone. After 13 years loading, she came back to me for further evaluation. No more bone resorption is seen, but the cortical bone is completely disappeared. This is another complication of the black bone.
Yeah, brings me back a lot of memories.
Graft failure, graft infection. The chin bone was
Can't believe I used to
harvested
teach these.
and grafted on the anterior maxilla for horizontal ridge augmentation. After 5 weeks healing, infection happened. I was very shocked to see these complications. So saline irrigation was done to control the infection. Was effective. After 6 months healing, the implant was placed but black bone on the site of a previous infection was not integrated. You can see the fractured segment here.
So what he did was, he knew that during the healing time there was some infection. He babysat it through until the enough time has passed so that the other areas where it's not infected, the graft has matured out, right? And then, but when he went in there, he was still able to do fixture placement. And he's going to do the fixture placement and implant at the same time.
So secondary GBR was done. Final restoration was delivered by my colleague.
Nice save, right? Nice save.
After 2 years loading, you can see the marginal bones here. So I'm not happy with this result.
He's not happy, he says, right?
This is my colleague's case. He did GBR with a simultaneous implant placement at the anterior aesthetic zone.
Tough case.
His first surgery, augmentation surgery, was failed and referred to me to control this complication. So these 2 implants were removed and soft tissue healing was allowed for 8 weeks. This is
Look at the defect, right?
preoperative cone-beam CT showing huge vertical and horizontal defect.
Now we call these
After
defects
2 months
three-dimensional,
healing,
right? When he says
full
three-dimensional
thickness was,
defect, he's talking about both vertical
elevated to
and
expose
horizontal.
the SPM
Okay,
side.
Siebert's classification,
Take a closer look at the huge defect. Vertical
which is
defect
one of the
about 6
hardest
millimeter
hard tissue
vertical
augmentation,
defect.
right?
So
3D
chin bone
defects.
was harvested for 3-dimensional ridge augmentation. 2-point fixation was done, and particulate autogenous bone chip was grafted on the residual defect, and the bone graft, particulate bone graft, was stabilized with the commercial fibrin adhesive.
Fibrin adhesive. I used to use those before PRF. It comes with a heater, and you have to mix the liquids, and you heat it up, and it turns into a glue.
And very good, tension-free delineation was achieved. However, 6 weeks later, the black bone was exposed. I was very embarrassed to see these problems. So flap was elevated, and you can see the pulse on the recipient side. So
Surprisingly, block bone graft
removed,
and Thai mash in my hands, I used to get a lot more infection.
And two tenting pole screw was placed at the same time on the same
So
day,
how does the rescue?
to support
The block bone, he removed it and did the tenting screw, and he's doing particulate now, right?
particulate bone graft during healing period. And antibiotic tetracycline soaked allograft was grafted for three-dimensional ridge augmentation and applied on barrier
So these are
membrane
old
on
cases that he's
placed
showing, I think, because I know nowadays he doesn't do that. He uses a sticky bone, he uses a Santa abutment. So he's just showing his past cases.
Made on periosteum and the buccal tissue. And the pregingival graft was done at the same time.
Did you get that? See, this is the problem with Professor Sohn, right? He does some amazing surgery, but he does not explain in detail. I almost missed that. What he just did now is one of the hardest surgical procedure, at least for me. He went in there secondary, right? So tissue was already shrunk. And he's rescuing the case that his block graft failed. So what does he do, right? He's trying to regain that dimension back. So he's doing a particulate grafting, but he need to have something to hold the volume up. So he used the two tenting screw. We used to use a tenting screw. We got something better now, but two tenting screw. And he put some bone in there, right? With a fibrin to make it a little sticky, right? But now the tissue, because it shrunk from a primary pullback, the scarring, he cannot get it. So what do you do? Okay, how do you get a tension-free flap? You peristyle release. Everybody knows that. So he did that. But when you do that, what happened? Okay, you lose vestibular depth, right? That's a side effect. So what he did was he scored it from deep inside, get a periosteal release, but also he released the buccal somehow at a different level, obviously, so that he can still have good vestibular depth, but more importantly, he can do a free gingival grafting. Okay.
To stabilize the free gingival graft, tetracycline.
That's a lot of a slick surgery, very high level surgical skill right here demonstrated, but he's not explaining well enough, so I'm here to explain to you.
After 4 months healing, excellent three-dimensional ridge augmentation was gained. Why did I use the block bone graft in this case if I can get this beautiful result with the particular graft material?
So he's telling that he's had enough block bone grafting failure to that changed the way he think about GBR. He realized that in his hand that particulate grafting was more successful than block grafting.
Is very stable now. Surgeons would like to treat challenging cases with complicated surgery, but patients don't want invasive surgery. So implant-related augmented surgery should be done as simple as possible to minimize patient post-operative discomfort. As an alternative to block bone.
So what he says, it's not the first time he said it. I've watched some of his presentation, and that is his mantra, right? His mantra is surgeon. Okay. His statement is that surgeons do complex surgery to impress other surgeons. But patients don't want complex surgery, right? And he's saying that from a perspective of the patient. He's not saying that one surgical skill is better than the other. I mean, we can all end up with a good surgical result if you know how to do meticulous surgery and follow the principle of healing. Okay, so some people say, oh, curry is better. Some people sausage is better. To me, it's not a right argument. Okay, it's not the right argument. Some people saying that backstroke is better than a butterfly stroke, or I've seen some doctors who are really, really good with the block grafting, and I've seen some doctors really, really good with a GBR, and ending up with just as equal result. Okay, but what he's saying here is very important, and I agree, is that those of us who do implants for a living, we want to find a simplified approach to a predictable result. And whenever we can, we want to minimize the surgery to 1 if we can, and at the most maybe 2. Because for me, simplified, more predictable, has a higher result. It might not be the 100% optimal result, but it'll be more predictable result and long-term stable result. Okay, and for implant only clinic like myself, and this statement holds very true.
Solid space maintenance. Take a closer look at the huge vertical defect here. So maybe more than 10 millimeter, about 15 millimeter high vertical augmentation was needed on the right posterior mandible.
Oh, he's talking about the bottom right side right here.
Is not suitable.
There's a nerve riding right up there, right? Okay, can you guys see that right there? Yeah. So he did a double-blinded study. I don't know if he told the patient. One side he's doing the GBR, the other side he's doing a titanium mesh. That's the one great thing about being a professor. He gets to do these and study it and write a paper about it, right?
I used the sandwich osteotomy with the interpositional bone graft for vertical augmentation. So
wow, there's 7 of you guys watching with me. You guys should be in bed. Welcome to my world.
And the pre-conditioned allogenic materials on the right side, and on the left side, the umbrella bone was segmented like this with piezo surgery and moved coronally about 9 millimeter high.
You know what that is? That screw? I used to do those. It's called a distraction osteogenesis. Okay. I don't know if this is the exact same one. The distraction was we'll get the patient to turn the screw and it will open up like 1 millimeter per week, and slowly it's like a separating the bone, and we're pushing it up, and slowly the blood clot will fill in and regenerate bone. It works, but it's a lot of work, man. It's a lot of work.
And to get vertical augmentation, this is a post-op radiogram.
Scott, you're a keener.
Was replaced after 6 months healing. Long implant was placed on the right side, on the left side. This slide shows you radiogram after 12 years in function.
12 years follow-up.
A little bit
that's impressive.
Bone disruption is seen on the right side, but it seems to be very stable. There is no bone loss on the left side because I used the pedicle bone graft using sandwich augmentation. This is not pre-bone graft. However, there are some disadvantages of titanium mesh technique, as shown on this slide. This technique is technique sensitive.
Very.
So, titanium mesh technique shows high risk of early exposure of membrane. Titanium mesh. So, when once mesh is exposed at early stage, the bone graft will be failed. So, titanium mesh is difficult to remove it after healing. So you need to consider there is always 1 or 2 millimeter thick connective tissue on the meshing. So you need to consider soft tissue when you place the dental implant after removing titanium meshing. So
You gotta place it deeper.
placement of dental implant.
Yeah, it's gotta be deeper after you use a titanium
I have
mesh.
many good cases using titanium mesh, but I like to share my failed, complicated case using titanium mesh. This lady came to me, and
That's the saying, titanium mesh. When they work great. But when they don't work, they fail miserably, okay? It's very, very unforgiving procedure.
asked me, is it possible to deliver immediate temporary restoration after implant placement? Wow, this is a very challenging case. I promise her, yes, you can get immediate restorations after extraction and after implant placement.
When I see a case like this, I'm not worried about the implant placement, to be honest with you. I can place it. I can probably do immediate teeth next day delivery. What scares me the most when I see a case like this is a soft tissue. It's got shitty soft tissue. And when you have to place these implants, I'm talking about FP1. Yeah, Dr. Sohn is similar to me. We don't like to remove unnecessary bone. We like to build bone. But to build bone, you need good soft tissue, right? You need decent soft tissue profile. Is already this case has a minimal attached gingiva, lack of vestibular depth. There's got so much of crap going on. This is a tough
After
case.
extraction, this is a preoperative panoramic view. You can see the huge vertical defect on the posterior mandible. After extraction, the immediate temporary denture was delivered. After soft tissue healing,
After soft tissue healing.
implant augmentation surgery and implant placement was done. This is a preoperative.
So he cheated. He cheated. So patient asked for immediate temporary prosthesis, and he wanted to give it, but he's smart. He knew that if he were to do extraction and implant placement and the provision at the same time, he's not going to pull it off because his soft tissue is so bad. So what did he do? He took those teeth out and gave him a denture, no grafting, just to let the soft tissue heal. And actually, that's very smart. So he probably negotiated with the patient, right? Okay, you know what? Just wear this, uncomfortable provisional temporary denture for 2 weeks. And then I'll do the surgery and the graft and then put an implant. And then he'll get the fixed prosthetics.
Showing huge three-dimensional defect on the both posterior mandible and maxilla.
There you go. Yeah.
This is a preoperative view after.
Now he's got a good tissue.
Soft tissue healing.
Now he can make it work.
So the implant was placed at anterior between mental foramen and some 2 or 3 mini implant was placed at the same time to deliver fixed immediate restoration after surgery. And titanium mesh was
Oh
used.
man, why titanium mesh?
To get good space maintenance after bone grafting.
If you have a good tissue though, it can work. Titanium mesh.
Immediate
If you have good
fixed
soft tissue,
restoration using
titanium mesh can work. But if it's a
1
crappy
implant
tissue,
and 2
you'll
dental
fail.
implant. After 4 months,
So what he did here is he gave the patient immediate fixed prosthesis, but not the way that I do, right? Okay. There's no right or way wrong. So in the old school, what we were taught is never to load implant at the same time of doing the surgical placement. Okay, because there was a big scare about immediate loading. Implant can move, it's gonna fail, blah blah blah. Now we know much better now. Over the last 15 years, we've done a ton of teeth in a day, and we know that we can immediate load. Okay, but in the old days, how we used to get around the fear was that put the implant, bury them, but in between the implant, we'll put a temporary implant. Okay, temporary implant that in between, and that will take the load during the healing, and it will take the load of a fixed prosthetics. And sometimes, we put maybe 4 or 5 of those in between the implant, and a couple of them have failed, but the other 3 will be still exist. So it's basically babying the case until the submerged implant they heal up, so that we can load those with the final prosthetics.
You can see the exposed.
What is that? Ah, that's exposure.
This is a late exposure of titanium mesh, but the augmented area was infected.
That's one thing.
All grafting material.
The block graft and mesh, if you get infection, you'll lose bone.
The most posterior
I mean,
area
any bone graft will get infection,
get
get loose bone, but like titanium mesh is a mess. Because to remove titanium mesh, you gotta make a big flap to remove it. Because those are hard to remove.
Using sticky conditioned bone graft.
So here again, he's rescuing it with sticky bone. Now, he's using sticky bone heavily, right? So many of you guys might not know the sticky bone is actually trademark. His trademark. So in theory, Professor Sohn can charge us every time I use the word sticky bone, okay, verbally or in print, because he owns that trademark name. Okay. He started sticky bone very early on his career, and he's been an avid user ever since.
Without the membrane stabilization suit. This is the right side. The healing was uneventful, but so bone healing was good. But take a closer look at the soft tissue formation under the titanium mesh. So when you place the implant, you need to place it deeper.
Yeah.
To the soft tissue. So 2 implants was placed.
So a lot of people get into a problem of implant fixture depth placement after a big GBR like this here. When you place a titanium mesh, even though you don't get an exposure, when you remove the tissue, that you'll realize that the tissue above the titanium mesh is very superficial. Very, very superficial. That tissue is almost like a mucosa, okay? You don't really have a periosteum layer underneath it. You have to move the titanium mesh, and there's a tissue underneath there, okay? And if you put the implant at that equal level of that, you're basically placing implants supragingivally. So in order to offset that, you gotta put the implant at least 2 millimeters deeper than that superficial layer, okay? Otherwise, you end up with a thread losses.
On left side, you can see the good 3-dimensional ridge augmentation without titanium meshing. It's amazing result. So 2 implant was placed. This is the final illustrations. This is 7 years in functions.
What kind of implant are those at the back? 2011. You see that on the top left side, and also quadrant 4, the back one. It doesn't have a thread design. Almost like an endopore. I don't know if they are or not, but hard to have any threads there. I used to use those press fit endopores. I'm not saying that these are endopores, but it looks very similar.
Even though I used particular sticky conditioned bone graft
endopores,
with the plasma
now in my hand, had a high failure rate.
Augmentation, but space maintenance was very, very excellent. There is no reason to use the black bone.
How you guys doing? Enjoying the show? This is a long one, guys, okay? So you don't have to stay up with me. I'm doing my own studying for very selfish reasons. So if you want to join and ask me a question along the way, feel free to do so.
Important role for 3-dimensional ridge augmentation as an alternative titanium mesh technique or black bond technique. So black bond grafting is not necessary for three-dimensional augmentation anymore. In my practice, I stopped using auto black bond technique for advanced ridge augmentation more than 10 years ago. If you want to get pure the vertical augmentation, I like to recommend use the sandwich technique with the interpositional bone graft. So once upon a time, I was a big fan of this technique, but I don't use this technique anymore because I could not implant the implants at the same time. So this technique has no effect on horizontal augmentation, but this is the vertical black bone graft, not pre-bone graft. So marginal bone loss is very, very minimal over time.
This is a very, very good technique to increase vertical bone height. It works really, really well. But one of the key points that he alluded to was that the reason he stopped using it, and I stopped using it as well, is because it requires some multiple surgery. Okay, so these are one of those cases that you do it to show off. Remember, he says surgeons like to do complex surgery to impress another surgeon. This will be it, right? Because it does one thing really well, which is a vertical height growth, which is one of the hardest things to do in GBR, right? But this technique does that really well. But you cannot do a simultaneous lateral ridge augmentation. Okay, so when you're doing these cases, it's almost automatic that after you get the vertical height, which will take about 5 months, you do secondary surgery to do. Oops, where did it go? Oh shit, I lost it. Okay. Let me go right here. Yeah, right here. Oh, luckily. What you have to do is you gotta come back into a lateral ridge augmentation and do an implant placement. So you're almost requiring at least like 2 or 3 or 4 surgeries, right?
In anterior, lower anterior area. This technique, this case report was reported in the
These are tough. These defects are so tough.
Official Journal of ICOY in 2007. So sandwich augmentation, sandwich osteotomy using piezo surgery was done after mobilization of this segmentation. This segment was moved to the coronary about 10 millimeter high.
10 millimeter.
And the microplate was used to stabilize this segmented block, pedicle graft.
And he's using a demineralized freeze-dried bone,
healing,
like a dynagraft. They used to be very popular back then. Not too many people use these days.
As I mentioned earlier, this technique has no effect on horizontal augmentation. So secondary horizontal augmentation using bovine bone and the pivoting adhesive was used for secondary horizontal.
So old school sticky bone, right?
This is 1 year. So vestibuloplasty was done at this stage.
Vestibular deepening.
This is 2 year. This is 5 months loading. This is 12 years loading. You can see 0 bone loss.
That's amazing.
With this technique. This technique has some advantages. So this technique was introduced by Jensen and Dr. Jensen in 2006. As I mentioned before, this technique shows you the very stable marginal bone loss thanks to
during this time.
Pedicle.
I remember it was like there was a wave of us taking this course. Sandwich technique, vertical sandwich thickening, and distraction osteogenesis. I remember going to courses to learn how to do this in the early during this time here.
So no donor side is required. but this technique has some disadvantages.
Dr. Sohn has joined.
There's no effect.
Hey, Professor
of
Sohn, I'm talking about you.
augmentation, and you cannot place the implant at the same time. So long edentulous period is required. If you wanna know.
That's one of
this technique more in
the
details,
problem with
please
these
read
technique
these
that I found
articles.
was that it's a multiple surgery. It takes an extra time of healing. So from a practice building perspective, patient focused perspective, it's not a practice builder.
The sandwich augmentation, and chapter 16 talks about the minimally invasive sinus augmentation without grafting material, without bone graft materials. We should consider patient-oriented surgery for advanced.
That's Professor Sohn's
not
mantra,
surgery,
right? Patient-oriented
centered
surgery.
So in order to do patient-oriented minimally invasive ridge augmentation, I like you to recommend to use a polybone or sticky bone for solid space
Absolutely.
maintenance. This
Single adjunct procedure that I consider a game changer, right? Game changer is sticky bone. Okay. There are different terminology like a PRF sticky bone or concentric growth factor sticky bone. I think at the end it serves a similar purpose. It just makes the rest of the surgical procedure that much simpler. Because of a sticky bone, literally many surgeries, cases that I used to do like 2 to 3 different surgery, I can do it in single visit surgery.
shows how to make your bone, particularly bone graft, sticky. There are 4 methods to make sticky bone. The oldest method is to use platelet-rich PRP, short-lived platelet-rich plasma, short-lived PRP. PRP was introduced by Professor Marx in 1980 to immobilize the bone graft and to accelerate the bone regeneration with the growth factors.
Hey Tan. Yes, this is my secret study club. It's the first time I'm inviting you guys for my late night study club. This is how I learn. This is how I learn. By watching somebody's lecture presentation and trying to really understand their fundamental philosophy and the concept. Because technique, learning technique from another surgeon can only get you so far, right? Technique, doesn't matter how good your technique is, if it doesn't serve the purpose of concept and the fundamental principle of healing, it's useless, right? So for me, when I'm watching like presentation of Dr. Sohn, I think he's one of the greatest surgeons in the world, and I'm more interested in his thought process, right? And one of the things about Dr. Sohn's lecture, if you are not keen on it, you'll miss a lot of pearls because he got so many great things in between the slides that will just blow by you. Because if you don't have a good fundamental understanding of why he's doing this, not necessarily what he's doing, but why he's doing it, that's where the real pearl is, right? Hopefully, I can help you understand his thought process. I'll do my best.
Second centrifugation, you can get the PRP, and this PRP is mixed with the grafting material, and you need to add the bovine thrombin.
That was the problem with the PRP. It's a labor intensive. You gotta add stuff in there, right? You have to spin it at such a high rate. Sometimes to do a multiple spinning.
I like to share some cases using.
That's why a lot of people it didn't really take off. Not like a sticky bone. Right.
After implant placement, you can see
it can work.
Huge
Definitely.
defect here. So PRP bone was grafted.
Sang-o, you're supposed to go to bed. You're working tomorrow, buddy.
Because PRP bone is secured with the fibrin network, so the collagen barrier membrane is not required in most cases in horizontal augmentation.
That I didn't know.
6 months later, wound was reopened. You can see the good horizontal bone regeneration with the PRP bone alone. This is the final restoration. This is the almost 20 years loading. You can see the
That's just
very
amazing.
stable marginal
20
bone
years
after,
follow up. Who does
19
that, right?
years loading.
I mean, you gotta respect that.
PRP has some disadvantages. This is technically sensitive, technically difficult. Double centrifugation is required, so the neurosurgery can be delayed when you prepare the
So
PRP.
what he's saying is a double centrifugation. Okay, I'll explain a little bit. Okay. PRF or CGF, constant growth factor, making a sticky bone, is a single spin protocol. Single spin without any additives. The old first generation of a regenerative, blood-driven regeneration, PRP, platelet-rich plasma, you have to use pipette, the Buffy code, and you have to collect enough blood to spin enough so that you can concentrate Buffy code. And after you collect it, sometimes you'll spin it again to concentrate it even more. And that adding additional material like a bovine thrombin, it just adds to the work.
You need to add the bovine
Hey, how you
thrombin
doing,
or
Shadan?
chloride salt.
Thanks for joining.
It is possible.
This is welcome to the secret study club, man.
There is possible cross-contamination from bovine thrombin. So you need to add some chemical additives. So only 10% of acquired blood.
That's why we had to draw a lot more blood, like 8 to 10 vials sometimes, because you can only get so little.
To use the sticky conditioned bone for three-dimensional reaugmentation. This slide shows you that several different commercial gel putty conditioned bone. Okay. Let me share some cases using this commercial putty bone for three-dimensional reaugmentation.
So what we used to do back then, before the PRF days, right? Before Dr. Bernard Jin made it, nationwide, teaching, and Shokun and all those guys, we knew that if we can find a way to make bone, graft material, allograft, commercial bone, or any bone, make it easy to handle. That is by making it sticky. So what we used to do is buy mineralized bone, which was like a BioOS or Rocky Mountain allograft, Kinsell's bone, whatever, and then we'll mix that with demineralized bone, like a Dynagraft, like a yogurt stuff, right? So we'll mix that together, and then you can make that sort of sticky. Okay.
This case shows you 8mm vertical defect. What would you like to do to treat this case? Black bone, iliac bone, or titanium mesh?
Those are tough to do.
Simple technique using sticky conditioned bone with the collagen barrier membrane. I placed the implant. This is the defect. I placed the implant at the same time on the defect as alternative to tenting pore to prevent.
Okay, guys. Every movie has a foreshadowing, right? This, what it's doing right now, is a foreshadowing for the later on, the invention of a Santa abutment, right? SANTA. And it's an amazing way to do a vertical and lateral ridge 3D defect augmentation. Okay, I haven't covered much on our Facebook or on Bytes Study Club, but we will be performing Santa abutment 3D vertical ridge augmentation with Dr. Bernard Jin next year during our live online study club. So don't miss it out. That is going to be the future of 3D GBR augmentation, and this is a foreshadowing. So he's showing, At this time, this is before the sticky bone era, right? He's talking about using an allograft putty and some sort of mixture to make it sticky. But look at the defect. 8mm defect, he guy's using an implant as a tenting screw. That is ballsy, right? Because what happens? Because a lot of us, when we're doing vertical ridge augmentation, not only we think about how it's going to work, but we also have to think about how it's going to fail. And when you have an implant exposed like that, and if the vertical ridge augmentation goes south, guess what's going to happen? You're going to lose the implant. Because the bacteria get contaminated, you lose not only the graft, also the implant. So this is a ballsy move, right?
Of the grafting materials, and pre-conditioned allograft overgrafting was done.
Overgrafting very important whenever we're doing this. That means we have to release the tissue a lot.
Without membrane stabilization.
And he talks about a 10mm rule, meaning that when you do partial release, it has to be 10mm beyond the opposing margin when you're doing a overgrafting.
This is a 12 years loading.
That's amazing.
You can see very, very minor.
I mean, how can he not lose bone even with an ugly emergence profile abutment? Because he doesn't do the restoration. The restoring guy does it. To me, the shape of the fat emergence profile of a stock abutment, that alone should cause a bone loss. But even after 12 years, he's not getting bone loss. So I'm impressed by that too.
Is it necessary? Is it essential to use the titanium mesh or black bond technique for 3D-dimensional ridge augmentation or Lemus plate technique? I cannot agree with that. This is a newly developed commercial conditioned bone, bovine bone. This bone contains the special bio-link, which is collagen. When you mix this bone with saline or venous blood or autologous fibrin glue or PRF or whatever, you can get stick conditioned bone immediately.
So those of us who don't like to draw blood
Even
and still want a sticky bone, you can get this product, right? I don't know where they sell it, but the bone comes with a cross link that when it acts with the liquid, it gets sticky.
Has some advantages. It is easy to make and easy to place on the bony defect.
I never used one.
No migration of bone
Putty S1 xenograft. I'm not a big fan of a xenograft anyways.
Will be shortened, and this is cost effective compared to the any other expensive putty allogenic materials. Okay, here's case using commercial putty bovine bone. You can see the vertical defect here. The full thickness flap was elevated.
Full thickness flap.
And you can see the horizontal defect here. What is your option to treat this technique? Titanium mesh or bony plate technique?
This one's easy, right? I would place an implant and do a grafting at the same time because the defect is minimal, especially the horizontal defect. Placing implant and doing a veneer grafting has been very, very successful for my practice.
I like to choose this simple technique. I like to choose patient-centered technique.
Wonder what he's going to do. I know what he's going to do, yeah.
So the bone pen, which is a surgical guide, was used to place the implant at ideal.
Okay. I've had some doctors ask me, what the heck is that? Because Dr. Sohn, he posts regularly on Begin, but he doesn't really explain. And these are called the ball pins, okay, ball pins. They come with a different diameter, and this different diameter represents the inter-implant fixture distancing, right? It comes in a kit. Why does he use this? Because I tell you what, he doesn't use surgical guide, okay? He's one of the old school freehand brain guided surgeon, and there are a lot of Gosu surgeon in South Korea who does perfect placement of implant without using any sort of guided surgery or even surgical stent. No surgical stent, no surgical guide. And one of the way how they evolved to be a better surgeon is using gadgets like this here. Okay, so these are the spacing that looks like a little pin, and then you use that to do the initial drilling.
Site and 2 implant was placed. The excellent initial stability was achieved, and to
That is Santa. Okay, this guys is amazing. Santa 1, Santa 2. The number represents the height of overgrafting. Okay, so he using a 1 millimeter over here because he doesn't really need to overgraft because the fixture is already slightly below the bone, neighboring bone. But here, he's got a bit of a vertical, doesn't he? Right? So from one corner to another corner, right here, I don't know if you guys can see it. Yeah, can you see my cursor? He needs to countersink this fixture at least about a millimeter below, okay? A millimeter below. Countersink it to the imaginary horizontal line. And he's using a 2 millimeter height Santa abutment so that he can overfill that, okay? Overfill that. Why do you need to overfill this? Because some of that little bit of bone is going to die back, just like a socket grafting, right? But because of the depth and the overfill that he did, is going to guarantee that even after the bone remodeling, implant's still going to be below the bone remodeling. Okay.
Grafting of bone graft, and to prevent the collapse of grafting materials, special tenting abutment was placed.
Yeah, and this one has a high surface area top. So some of you guys were asking, can you use a healing abutment? Yeah, I've used healing abutment in place of this in the past. But these work much better because it's got a narrow neck to hold the bone above, and also flat top. Okay, flat top, so that it disperses the pressure to the overlying soft tissue, so that it does not tear out as easily.
Placed on the implant platform. This is the Santa 2, which has a 2 millimeter curve high. This is Santa 1.
I rarely use Santa 1. I use Santa 2 predominantly.
So
this is what you mean, yeah.
Putty condition, the bovine bone was grafted on the deep end.
What kind of bone you use doesn't really matter. Any particulate, but I think it's important that you make it into sticky bone, either with the putty or PRF. You want something that's stable, because here we're not using any mesh or anything, so it will rarely work if you don't use sticky bone. You know, when you're using a Santa technique, in my opinion, sticky bone is a must.
And collagen barrier membrane was placed over the bone graft without special stabilization technique. Simple placement.
He just does membrane, no bone tacking, no nothing, and then
placed over the collagen barrier membrane.
He's using a membrane, right? Paraffin membrane, CGF membrane for the soft tissue closure. That's what it does. It will speed up the soft tissue closure.
This is tanning. You can see that the bone of the.
You see that right here?
Santa, or the head of Santa. The uncovering was done after 6 months. Because of COVID crisis, the uncovering was delayed. Wow, you can see the beautifully augmented, vertically augmented.
This is what I mean. When you need to countersink the fixture, right? By the way, Professor Sohn designed this, if I remember correctly, right? Santa, the S stands for Sohn, Professor Sohn, that he put his name there. But the Santa abutment, according to Dr. Professor Sohn's teaching, is that you need to sink the implant depth appropriately. So if you don't sink this enough, and then you put a Santa above, it won't work because the amount of the bone has to overgrow is going to be so high. So that right here, right, you draw the imaginary line, and this fixture is at least about 2 millimeters below.
Reach here. The third method to make your particular bone graft sticky, you can use the commercial fibrin adhesive. The fibrin adhesive is indicated to control topical bleeding, soft tissue bleeding, but you can, when you mix with this fibrin adhesive with the bone graft, you can get sticky condition on the bone immediately. Okay, let me share some cases using sticky condition on the bone using fibrin adhesive. What are the options to augment this huge defect? What would you like to do in this area? This posterior mandible shows about 6 millimeter vertical defect. Would you like to use the complicated technique or simple technique?
These are tough, right? Because when you have this much of vertical defect, and the distal of the 4-5, this premolar here, is already lost so much bone. I know there's a little bit of bone here though. Okay, I'm almost, like telling you honestly, I'm almost tempted to take this tooth out and place an implant right here, and trying to see if I can squeeze one behind it back over here, right? Right. And trying to do some bone augmentation over here, and then maybe 4 months later or something like that, I would place another implant behind right here, right? And when I do that, I can give a temporary a bridge spanning from over here, okay, the 4, I think that's a 4, yeah, over here, the implant from here to over here, right? So the patient can start to function while my implants in the middle is healing up. That's one of the way of doing it. I don't know how he would have done it.
Black bone or ring bone, messy, or the bony plate technique as a staged procedure. I prefer to the patient-oriented, patient-comfortable.
I'm pretty sure he's going to show how he used the Santa, right? Because that's what the lecture's about.
As a one-stage procedure in order to reduce edentulous healing period. This is intraoral view.
The soft tissue sucks. Minimal touch gingiva.
The first
look at the nerve.
Was elevated. And
oh, he did take it out. You see that? He did extract it.
Before implant placement to get good primary tension.
He did, right? He did extract that.
And the mixture of bovine bone and allogenic material was mixed with fibrin adhesive to make it sticky. The 4 implant was placed.
So he did take the premolar out.
Tenting pole
he put the implant there, and he put the implant here. But he put 2 additional ones.
Screws on the defect. Why don't you place the implant at the same time? So the bone graft was placed.
These are not Santa abutments.
Was placed.
These are almost like a cover screws.
Under the lingual flap, and the fibrin glue was applied on the grafting material to stabilize the particulate bone graft. The simple placement of a collagen membrane was done. Primary suture was done. After 7 months healing, wound was rebuilt. Temporary restoration was delayed.
He's gotta do a free gingiva grafting.
Please note, take closer look at the no attached keratinized gingiva around implant restoration. So after making apically repositioned flap, the sutureless free gingival graft was done.
You know what this is? Now he's going to publish a paper soon. It's called the sutureless free gingiva grafting. I mean, it's not 100% sutureless because there is a anchoring suture to keep the soft tissue down for the recipient site. But where the sutureless term apply is the donor side. When he takes the free gingival grafting out of the palate, he does not use suture to hold the hemostatic agent. He just puts the cyanoacrylate, right, as a hemostatic agent, and also on the recipient bed he puts a little bit of attacking cyanoacrylate in the corners, 3 corners of the free gingival grafting. That's all he does, nothing else, right? And his article should be coming out very soon. I will notify you, and I'll post up the article when he does publish it, because I've had the honor of putting my input into the article. So and pretty exciting.
This is final result. This is follow-up radiogram. This is baseline. This is 10 years follow. There's a little bit marginal bone resorption here, but generally speaking, the marginal bone looks like.
Look at that. That's amazing. These implants were like above, like the threads were totally exposed. And to be honest, like these design implant, they're not the best for these kind of a GBR either. But he still, regardless, made it work.
Stable with this simple technique.
I mean, he's using an implant thread with a crappy design, and the restoring dentist kind of sucks too, but still gets a good result.
These are allogenic materials. So some patient concerned cross-contamination and from bovine thrombin and allergic reactions.
Yeah, I agree with you. It's an awesome result.
The advantage of this glue is very expensive. So I prefer to use the autologous fibrin glue instead of using.
Are you guys having a good time? I'm having a great time.
Fibrin glue, if possible. So this slide shows my favorite method to make sticky condition the bone using autologous fibrin glue, shortly AFG.
See, my surgical career is divided into 2 phases. Before pure sticky bone and after sticky bone. Okay.
After taking venous blood, patient antecubital fossa, this blood or venous blood is divided 2 different tubes. This is a yellow cupped 100% the plastic test tube. This is the lead capped glass or glass coated tube. After 12 minutes, first 2 minutes centrifugation, you can see the 2 different layers in the yellow capped tube. The upper layer is autologous fibrin glue. So in order to make sticky condition, but you need to mix with the upper layer of the in the non-coated tube. After another
Oh man, you have a surgery all day tomorrow.
Centrifugation, you can see the
Well, you know what?
different layers in
This is
lead
amazing.
capped tube. The middle layer is the fibrin
To be able to
block
share my
containing
learning
concentrated
process
growth
with all of you.
factors, shortly
So,
CGF.
he calls it a CGF,
This
concentrated growth
slide
factor.
shows you how to make sticky bone within 1 minute. After mixing grafting particulate graft material with AFG, I like to recommend you add coagulation factor attached to the CGF block to accelerate original sticky bone formation.
It's similar to Dr. Bernardin's protocol at Bice Institute.
Hold CGF block
Slightly different.
with a cotton flyer
So what he's doing is,
and cut alveolus layer.
see that he also leaves a little bit of a red behind, right?
Make sure to get a little portion of alveolus layer.
Yeah, that red
this
layer.
Alveolus layer contains coagulation factors, such as platelet. large platelet. So after you need to compress this CGF membrane.
So when you compress that, what happens is a little bit
CGF
of the red attachment, that bloody part,
membrane,
that will flow
and
into the
mix
the white
with mixture
clear
of
liquid
particulate
from the
bone
white
graft and AFG.
tube, and that will activate
Within
it.
1 minute, whatever you use as a bone graft, you can get original sticky bone simply, easily.
So similar, right? How Dr. Jin teaches is just cut out the red part into little particles and then mix it. He just squeezes it and then use the liquid out of it.
Yeah, you can see it's very solid, elastic condition of sticky bone. Dr. Jin Kim, Eric Ban, and Eric Park and I did the 4 days live patient surgical program together in 2015 and 2016.
I'm definitely going to invite Dr. Professor Sohn to Canada
make sticky bone to all
when this
attendees.
pandemic is over, because he's an
So even
incredible
though they made
surgeon and
they
presenter.
tried to make a sticky one at the first time, all attendees
We can learn
were
so much from him.
to make sticky condition the bone.
They're
They
wiggling
was
it.
very happy with this result. That this sticky bone
It's a game
can
changer,
make
right?
your,
Sticky bone.
candidate
How can anybody
augmentation
deny it?
simple. This slide shows you some benefits of sticky bone. You don't need to use mesh or block bone for three-dimensional ridge augmentation in most cases. You can get faster bone regeneration thanks to the concentrated growth factors in sticky bone. You can place this graft material on all types of defect easily, and you can get a minimal loss of a bone graft during healing period.
So what I do is this, right? Is all sticky bone density the same? No, it's not. Okay, it's not. I don't talk so much about that aspect. I will cover it at the study club one of these days, but depending on the defect, you want to be able to concentrate how much particulate particle gets encased in the sticky bone. Like for example, if it's a lateral window sinus, I don't want too much of a particulate. I want mostly of the PRF volume, and I want the less of the particulate, because when I'm doing an implant, the tenting is done by the implant. I don't need a lot of particulate in there. Less is better. And Professor Sohn, he wouldn't use any particulate graft. He'll just use a PRF gel only for the lateral window together with the implant. However, when we're doing a Santa abutment type of a procedure, you want that sticky bone to be dense, right? You want it to be sticky but dense. That means that you don't want to mix too much of a PRF membrane or you chop it up. Okay, I will minimize the chopping, because the more you chop of a PRF membrane you put in, you get the volume, but it's not as dense, right? So when using Santa, I mix it like he just showed right there. Okay, you get much more dense and condensed, highly dense particulate encased by the
this slide shows the same image of sticky bone presented by
growth factors.
Professor Oliveria. This is a bone graft. You can see the bone graft surrounded with the fibrin network. This is the blood cells entrapped in the strongly interconnected fibrin network. So, sticky bone works well with all kinds of grafting materials. Nowadays, there are many copies of the original sticky bone. They call IPRF bone or sticky bone, PRF bone.
Those are
or
copies
PRF
of Dr.
black,
Sohn's sticky
or,
bone.
they
I mean,
call
he
it,
has a legitimate
PRF
argument,
bone.
right? Because he's the first one to actually publish the term sticky bone, right?
So original sticky bone plays a role of solid space maintenance in the ridge augmentation. As instead of using black bone, carbon screw, mini screw, or titanium mesh, I recommend to use sticky bone for ridge augmentation in order to patient-oriented practice. This is the case using sticky bone for 3D-dimensional ridge augmentation. This is a preoperative cone beam CT. Wow, take a closer look at the
He's got
very
nothing
low
there.
residual bone height on posterior maxilla, less than 1 millimeter. So full sequence
There's perforation
was
there too,
elevated. Now
in the
you can see
sinus.
the bony communication through the
Or
the
antral
sinus
fistula.
mucosa. You can see that the mucosal perforation here. So when the sinus mucosa is perforated like this, we cannot use the crestal approaches. So lateral approach to sinus augmentation was used with the physioelectric bone surgery. You can see the artery inside the bony wall. Replaceable osteoinductive bony window was prepared with the physiosurgery. Make sure to do the bevel osteotomy at anterior osteotomy line and inferior osteotomy line in order to prevent the displacement of bony window after sinus.
So what he's saying is that I don't use this technique because I think to me it's a little bit of a time consuming, but here's a rationale for it, right? There's a study that saving the lateral bone, okay, you like a can opener, you open it up, and then after you do the sinus grafting, you put it back, and that almost regenerates the entire buccal wall as if nothing happened. But in order to do that, what he's saying is that you want to bevel the edges in an angle so that when you put it back, you don't accidentally push it in, right? You want to bevel it.
Elevation. It is very risky to use burr in this case because the severe arterial bleeding is possible. So I strongly recommend to use physiosurgery to protect the artery inside the bony window. Thanks to physiosurgery's selective cut effect, the damage to the artery is very, very minimal during osteotomy. It's not a good idea to remove lateral wall with surgical burr. This bony window is osteoinductive barrier windows, so don't waste this bony window with the surgical burr. You need to save this window.
What it's saying is it's osteoinductive. It means that it will itself will regenerate bone. It doesn't resorb away.
Sinus mucosa is elevated. The implant was placed at the same time after doing on the osteotomy to get good stability of implant. The implant was placed. Implant acts as a tenting pore screw. In this case, the bone graft-free sinus augmentation was done. And
Did you see that? He didn't put any graft material. He only used PRF gel, right? Because the volume is maintained by the implant itself.
And one piece of the sticky bone, bovine bone, I think it looks like a mixture of the allogenic and bovine bone, was placed from palate and to the buccal over the crestal area. Collagen membrane was placed simply, primary suture was done. This is the post-op.
She didn't even have any bone. How did you get the stability?
You can see the
Amazing.
100% vital new bone formation living bone inside the sinus cavity. You can get
You see that right here? Top right side, quadrant 1. You don't see the radial opacity that you see with like a bovine bone or allograft material, right? This is basically the radial density of a blood clot. Blood clot, my friend. Okay. And almost look like the same radial density as a retention cyst, right? Okay. This is because this PRF, sticky gel, or CGF gel is basically like a blood clot. Okay.
get good.
That's why you don't have that density.
Augmentation here, even though some bone
And 6 months later,
migration, bone resorption
it comes
is
down,
seen.
but it's been held by
This is
the
a final
implant fixture as a
illustration.
tenting.
The simple 3D augmentation using sticky bone is always predictable. In narrow alveolar ridge, no, I don't think so. In some cases, when the alveolar ridge is very narrow, even though I use the sticky bone, the bone can be migrated apically because of the soft tissue pressure to the implant platform, as shown in this case. So vertical implant was placed at the same time as an alternative to the tenting pole screw. And take a closer look at the very narrow alveolar ridge. Sticky demineralized osteoinductive mid-tooth bone graft was done, and the collagen membrane and CGF membrane was placed on the bone graft. This pre-op, this is 3 months later. You can see some marginal bone resorptions here. So when the bone resorption, when alveolar ridge is very thin, maybe we need a more secure space maintainer, such as low profile healing abutment or Santa. This is a temporal restoration. Stability of overgrafted bone graft over implant platform is essential for predictable 3D ridge augmentation. Therefore, a low profile tenting abutment plays a role to maintain the volume of grafting material during healing period.
Yeah, that's one of the prerequisites for when you're using a tenting screw,
this
that
case using
you need
tenting,
to
abutment.
overgraft the site.
Huge vertical defect here, and the bone was very narrow here. So the ridge split technique using piezo surgery and ridge expander was done. After implant placement, the buccal plate was fractured. What would you like to do to control this problem at this stage? Would you like to place the micro screw? Impossible when you place the implant at the same time. The simple way to stabilize the fractured buccal segment is to place sticky bone over the fractured segment. To support the augmented the alveolar ridge, augmented bone graft coronally, the 2 mm.
I can answer that, Shadat. He and I, we had a discussion about it. No difference. No difference. It is important to clean all the soft tissue out, but whether perforating or not that much of a clinical difference.
Layers CGF membrane was placed over the bone graft instead of using collagen membrane. This is before. This is post-op. This is 4 years in function. You can see the excellent vertical augmentation with very minimal loss of bone graft. Thanks to tenting pole abutment, the vertically augmented bone graft did not migrated apically during healing period. Here's another case using tenting abutment for 3D-dimensional augmentation. Take a closer look at the huge vertical defect here. The soft tissue was elevated to see the bony defect, piezoelectric bactericidal curettage was done before bone grafting.
Another thing about Professor Sohn is that he is the king of piezo sinus lifting.
With water pressure without bone grafting.
The special tip that he developed,
simply with water pressure. And
this is by far the fastest way to lift a sinus, way faster than casket, way faster than supper. That thing lifts in like a few seconds. It's almost scary.
Were placed. And two implants was placed.
I think those are what, Zimmer implants?
You can see the partial loss of the buccal wall and complete loss of the.
Oh, thank you, Dr. Sohn, to replying that. That's why I told Dr. Ayugi as well.
The tooth bone graft was placed after placing 2 mm high tenting abutment on.
So these are not center abutment. Center abutment are a little bit different in shape. He's just using it as a tenting abutment, the traditional tenting abutment.
25 to accommodate customized titanium meshing. For comparison, I used two different techniques in this case. So on CGF membrane was carved over the bone graft.
Those titanium micro meshes are like, you know, Hyosin sells it as a smart membrane.
Take a closer look at the
I used to use them, and later I stopped using it because I didn't find that it was necessary.
Spacer. Titanium mesh
Exactly, that's what happened to me too.
Healing, so I did uncovering procedure.
Sometimes they get exposed.
Titanium mesh in order to prevent possible infection. This is before grafting. This
Titanium
is
mesh
3
never really
months
worked
to
that
its
well
healing.
in my
This is
hands,
the
you
good
know.
bone regenerations around the implant. This is the before. This is the baseline. This is
beautiful.
6 years loading. You can see the very stable marginal bone thanks to the
That's the thing, right? How can you argue with the 6-year follow-up, right? That's impressive.
Grafting. Here's another case.
That should be a full arch.
This
That's
is preoperative intraoral view. This patient,
oh wow.
when this patient visited me, he asked me
Hey Arif,
to give him
long time no see, my friend.
restoration after implant surgery.
Good
Is
to
it
see you,
possible?
Arif.
Yes, I think so.
Those are ball pen.
As I mentioned on previous case, after extraction, immediate denture was delivered. After soft tissue healing, implant surgery and augmentation surgery was done at the same time. You can see the huge.
See, that's another take-home message, right? Okay, there is a poetry, right? Bone sets the tone, but the tissue is the issue, right? Doesn't matter how good of a surgeon you are, if your soft tissue cannot hold the graft in place, it's not going to work. That's why Professor Sohn here, I believe he did extraction first and do a immediate denture for a few weeks for the soft tissue to heal up before he does this massive implant placement and simultaneous grafting.
Left posterior mandible. So for the as alternative to the tenting,
No shit, that titanium mesh don't work in my hands either. I always believe that those people who show their cases, titanium mesh, they only show the cases that they were succeeded with. They don't show the case that failed. Yeah, buccal places the fate.
On the buccal around premolar implants. And
This, I want to learn. Not because necessarily I need this to make my cases work, but I want to do a study where this compared to a curry technique, because curry is taking the ramus bone and trimming it and placing it like this, whereas he's using a natural tooth. These are demineralized teeth, which is far less invasive.
And these implant also used abutment for immediate fixed restoration. And 3 mm high tenting abutment was placed to allow or to prevent the collapse of grafting materials vertically. So patient extracted teeth, all teeth were prepared to osteoinductive bone graft after decalcification and sterilization process in vacuum sonic machine.
Vacuum sonic is a machine. I'm not sure if it's Health Canada approved. Maybe in the States they're approved. And allows us to avoid a donor site like a ramus or chin, which is a big plus for patients.
Membrane was placed around around the over bone graft. This is the intraoral view after suturing. Immediate fixed restoration was delayed. This is post-operative radiogram. You can see that the vertical defect here.
That's a lot of grafting. That's a lot of grafting.
Is tenting abutment for comparison. This is that because this area shows small vertical defect, and horizontal augmentation using tooth bone was done here. 6 months later, you can see the beautiful vertical three-dimensional ridge augmentation thanks to the tenting pole abutment. This is before grafting. This is the 6 months healing. The healing abutment was removed. You can see the
that's because of the overgrafting.
Over the implant platform.
That's what the tenting abutments help to do. Allow you to overgraft.
Here, sticky tooth bone alone was used, and I did the horizontal augmentation here with the same graft.
I mean, we're impressed, but what really does, what he's doing is he's following the principle of healing, right? Tension-free flap, sticky bone to maintain the space. And one of the reasons why this actually worked, okay, I believe, is because he did immediate loading. Can you imagine? You do all this grafting, and then patient with a denture and the denture is not fitting properly, moves left and right and back and forth. It will destroy his graft. Okay. I can almost make a statement that because he used this temporary implant to take the load off the graft, one of the main reasons why it was successful.
Wow, look at the beautiful newly formed bone.
Because he's academic, he has access to a histology, right? This is what makes Professor Sohn's work legitimate. Never seen anybody do that level of patient-oriented surgery and at the same time follows up for 10 to 20 years and does histological studies. Like, the guy's amazing. Such a unique position that he has when it comes to academic and clinical applications. Yeah.
Would you like to cast away patient extracted teeth to garbage, or would you like to make a novel osteoinductive bone graft after extraction? Unextracted tooth is no longer biology waste, so you can make particulate osteoinductive graft material.
So he's going to get into this, right?
Osteoinductive black bone or ring bone at chest side. According to the several publications, tooth bone should be decalcified before using it to accelerate bone regeneration with release the diverse growth factor. If you do not decalcify enough tooth bone,
so now he's getting to a fundamental concept of using tooth bone, using a teeth as a way to help with the bone regeneration.
You can make particulate tooth bone within 20 minutes, but you need 1 hour or 2 hours to make tooth bone, tooth black bone.
2 hours, that's a long time.
Sonic device. This
But
is
look at
my
that. Doesn't it look like a
old
curry?
augmentation using
You know?
the black bone. I don't use this technique anymore. So if you,
See, one on the right side, like I don't know. See, this is the thing. Right now, like the curry bone block is such a like wave, right? That's everybody wants to do a curry technique, right? But the thing is, we were doing these like 15 years ago, many years ago. Dr. Sohn's been doing this many years ago. But the only difference now is that instead of using patients' own ramus bone or chin bone, we're able to do something very similar using patient's teeth, which is totally possible because when you're doing a full large cases like that, you're taking a lot of teeth out. A lot of them is periodontally diseased, but the actual tooth structure is intact, right?
present technique using tooth block.
Oh, I love that photo. That's amazing.
This is my teams. They published the study on comparative morphometric evaluation of bone regeneration with different preparation of genogenic tooth bone block. 4 different types of tooth block was used to evaluate new bone formation. The demineralized the human tooth bone with a hole shows the fastest new bone formation between bone block and the host bone. Now you can see the excellent newly formed bone over the tooth block.
That is impressive.
Amazing.
So what he's saying is that study shows that we don't necessarily need to make holes in the recipient side, but the tooth bone, it helps to have a holes in there, right?
At the junction of the
That's useful to know.
host bone and the tooth block. Here's another case using simple. This is the comparison of the simple technique.
Look at that. He did some ortho as well.
Complicated technique using titanium mesh. This both cases shows you very similar situation. So on the left side, these 2 teeth was extracted and prepared to the inductive bone graft at chest side and immediate implant placement and rejuvenation.
You see the trend here? A lot of you guys will probably miss out on it. She doesn't take the tooth out and do the implant and bone augmentation at the same time. He takes the teeth out first, let the tissue optimally heal for the few weeks before he go in then does his work. That's respect to soft tissue, soft tissue biology.
Delayed rejuventation with simultaneous implant placement. You can after implant placement on both sides, you can see that the 7mm
See, to
vertical
do
here,
what he does,
you can see the 3mm
it
vertical
requires a
defect,
certain level of a religion. You gotta believe it. You gotta believe in the biology, believe in the sticky bone, believe in the soft tissue healing, right?
The 2mm high tenting abutment was placed on the left
As
side.
much
On
as
the right
this is a
side,
simplified procedure, there's nothing
2mm
simple about
space
execution.
was, placed
There's
to
no room for
accommodate,
error.
Titanium mesh. The simple GBR using sticky tooth bone was done on the left side. On the right side, the titanium mesh was placed and the 3-point fixation was done. This is a very complicated technique, time-consuming
Yeah,
technique.
titanium mesh is oh my god. Yeah.
This is before, this is a post-op X-ray. You can see the good you can see the grafts and materials over the tenting and pore abutment.
Thank you, Professor Sohn,
After
for
4 months healing,
edit.
wound was
You know what, you guys? You guys are so bloody lucky tonight because I went live on Begin without any formal advertisement or promotion. I go in. Initially, I was going to do this because this is what it's for me. I'm studying for myself, right? It's nothing got to do with you guys. This is what I do, right? I follow Gosu Surgeon. I watch the presentation. I take notes. That's how I hone my skill. But I decided to invite you guys in because it's Christmas holiday. And guess what? As a bonus event, Professor Sohn joins all the way from half away from the globe, right?
on the left,
You guys are lucky.
on the left side, you can see the good bone regeneration degenerations around implant. On the right side, 5 months healing was revealed. You can see the good bone regeneration, but this is not bone. This is the 1 or 2 millimeter thick soft tissue.
Yes.
You can see the bone regeneration under this soft tissue.
Periosteum, right?
This is the before. This is the real function. This is the before. This is a 6-year function. Both cases shows you the same result, very predictable result. So you don't need to use a complicated.
This is an impressive clinical study that he's done, right? That's one of the advantage of Professor Sohn in his clinical setting. He is a head of the oral surgery department at Catholic University of Daegu. He has an unlimited number of patients. He's able to study on a same patient 2 different techniques. Now here's the meat of the matter, guys. Santa. This is going to change the future how we do a vertical and lateral ridge defect. We'll cover this in our study club next year with a lecture and live surgery. But consider this as a foreshadow.
You can use this one for immediate implant placement in extraction socket. Santa has some advantages as shown on this slide. The Santa prevents collapse of bone graft during healing period and maintains the volume of grafting materials. And Santa technique is a simpler and less invasive augmentation procedure compared to the other complicated augmentation techniques such as mesh or block bone or bony plate technique. So you need to place the implant at the same time to use the Santa, so you can reduce number of surgery as a one-stage procedure. So you can shorten eventual healing time.
One surgery.
Okay. Let me show you how to use Santa 1 for horizontal augmentation. Implant is placed 1 millimeter deeper to the alveolar crest.
This is the fundamental surgical concept.
Santa 1 is placed, and bone graft was done, and the collagen barrier membrane or CGF membrane was placed over the bone graft and primary suture.
And because of this long flat head, which is 6 millimeters, which extends also to the buccal, it prevents the bone from sloping down in an angle. It keeps that dimension solid, especially when you use sticky bone.
The Santa, the grafting material does not migrate because the Santa resists the soft tissue pressure to the implant platform.
Yeah, because
And
it's flat. Evens
the
out the
bone
pressure point.
around the neck of the implant platform also well maintained. This case,
It's an ingenious design.
this was extracted and this was extracted. Immediate implant placement was done. The bone pen was used to place the implant at ideal site. 3 implant was placed. So you can see the 3 implant, 3 millimeter high vertical defect here, and you can see horizontal deficiency around implant. This is the occlusal view.
So
Santa
those of us who are not
placed
used to
for
seeing
vertical,
threads above the
ridge
bone,
augmentation
this is not very
on the
comfortable
number
slide to
47,
watch, but you gotta have a faith in it,
side,
right?
And Santa 1 was placed on the
He used the 1 millimeter
number,
one for horizontal because you don't need to grow
6
vertically, but for the
implant
vertical
for
one, where the threads are exposed, he used the 2
sticky
millimeter because you need to
bovine bone
overgraft
was
it. Because
placed
Professor Sohn also
around
talked
the
about the
Santa,
importance of overgrafting. That's one of the prerequisites to make the
collagen barrier
a
membrane
vertical
was
Santa
placed simply.
augmentation
And on the
predictable.
number 4, after bone grafting, Sohn's pancho technique was done. The primary suture was done. After
That
3
suturing
months
was
healing,
the internal
3 months,
mattress,
2
right?
weeks healing
Eversion
was
suture that we talk about,
exposed
eversion,
again
right?
to
Like this.
evaluate the bone formation. get a very beautiful rich augmentation. There is no migration during healing period thanks to Santa. The final restoration was delivered. This is pre-op. This is X-ray after
That's impressive.
uncovering. This is 6 months.
See, the thing about this is, right, he's showing so many different cases, so many different implant systems. That's telling you,
Let me talk about a little bit
fundamental principle of healing is more important than any implant design that you use.
This is a surgical method to stabilize the CGF or PRF membrane using healing abutment or prosthetic abutment at implant site. This technique was described by me in 2008, and now it got popularized by the world simply
Pancho.
Pancho technique. So CGF membrane is pierced with a cotton fly or pincet or a blade to pierce the healing abutment to stabilize.
I'll forever see that slide. Professor Sohn wearing a poncho embossed in my head now. Every time I'm going to do this poncho technique. That's cute.
Abutment to stabilize the CGF membrane and stabilize the grafting material under the CGF membrane. This technique has many benefits. The CGF membrane accelerate wound healing at extraction socket, and this CGF membrane stabilize the grafting materials during healing period. In many cases, you don't need to do the shoot at this stage, so you can minimize the suturing time. So this technique makes flap manipulation simple and easy. So post-operative complications are very minor. You can maintain zone of attached catenized gingiva with this technique. This slide shows you indications of Pancho technique. You can use this technique for single or multiple immediate implant placement as a one-stage procedure with a grafting bone graft, or you can use this technique GBR without bone graft at sound extraction socket. You can use this technique GBR with bone graft at extraction showcase showing bone resorption. This technique indicated for management of fatty implantitis. Okay, here's case using Pancho technique. This patient came to me from New York City, USA. Before she visited me, she came to several dental clinics in New York City, and she asked immediate restoration after extraction. All dentists refused to deliver the immediate restoration, so she came to me whether immediate restoration is possible or not from New York. So I promised her to give her immediate restoration after implant placement.
It's an interesting case because her oral hygiene doesn't look that bad, but obviously all her teeth are failing.
On the same day, all extracted mandibular teeth was prepared to the sticky osteoinductive MTB.
Oh, tooth bone. He's using those extracted teeth as a tooth bone.
Each
Same day.
posterior mandible, and the bone graft was done with sticky bone, and Pancho technique was performed to accelerate wound healing, soft tissue healing. This is left side. The bactericidal curettage using piezo surgery was done, and 3 implant was placed, and sticky tooth bone was placed.
So these little particles are not allografts. Those are bone material that's been grounded now. The tooth material.
Done to accelerate.
So vacusonic.
Primary wound clot was done, but you can see some exposed CGF membrane here, but the wound healing was not eventful. The excellent soft tissue healing was achieved thanks to the CGF membrane. immediate restoration was delivered on the next day. This is a post-op radiogram. You can see the grafting materials around implant, vertically augmented ridge here. The final restoration was delayed after 5 months healing.
That's beautiful tissue healing.
Post-op. This is 2 years on the 2-year loading on the right side. This is the post-op. This is a 2-year loading on the left side. You can see the well augmented alveolar ridge. This slide shows you Santa 2. Santa 2
This is by far my favorite height, 2 millimeter.
Vertical augmentation. Santa 2 has a 2 millimeter cuff height. So when you do
Dr. Sohn replied, is there a diameter more than 6 millimeter? He said there's a 7 and 8. I didn't even know there's a 7 and 8 millimeter wide Santa. But he said 6 millimeter is the most popular and it's easier to use. So thank you, Professor Sohn.
1 or 2 millimeter deeper to the proximal adjacent marginal bone. And place Santa 2. Overgrafting is
so you need to
be done and
place it slightly deeper and overgraft.
Here's a case using Santa 2. You can see the mucosal thickening because of the hopeless teeth showing severe periodontitis. So these all teeth were extracted and prepared to the osteoinductive bone graft at chair site. This is the 2 weeks healing, 2 months healing. The mucosal thickening was reduced. What are the options to augment this huge vertical defect and sinus augmentation? Would you like to do complicated procedure using bony plate technique or Blackman technique or mesh technique? Would you like to do simple technique using sticky bone? This is pre-op beam CT. Pore thickness flap was elevated. As soon as the buccal flap was elevated, the huge defect or the 10 millimeter bony communication was rebuilt, and second, small bony communication was rebuilt.
Jeez, that's pretty big.
Take a closer look at the huge sinus mucosal perforation. So it's very risky to place the grafting material, bone graft material, in the sinus cavity under the perforated sinus mucosa, even though collagen barrier membrane was used for mucosal perforation, for the repair of mucosal perforation. According to some study, about 17% of mucosal sinus infection was recorded under the perforated sinus mucosa. So osteoinductive, the ROB window, bony window was prepared with piezo surgery, and the sinus mucosa was elevated with the sinus elevated from lateral window and bony communication.
He's placing implant, oh my god.
Osteotomy was done.
Oh, it's got the balls of steel.
And the 2 implant, the biotech implant was placed.
He's got one of the best periosteal releasing skill that I've seen.
Releasing was done before bone grafting.
10 millimeter. He needs to be overextended.
Make sure to get
10 millimeter.
10 millimeter overlapping over buccal flap over the palatal flap to get tension-free primary shoots. After on the osteotomy at implant site, implant should be placed to get stability of.
What is it placing in here?
To repair the preparation of large preparation of mucosa, past resorbable gelatin sponge was
gelatin
placed.
sponge. Okay.
This gelatin sponge holds the blood coagulum under the elevated sinus mucosa, so accelerate bone degeneration during healing period.
Okay, guys, this is important. He deliberately didn't put particulate graft in here. Why? Okay. you need to be able to read between his statements, right? He talked about the literature saying there's a higher chance of sinusitis when there's a perforation, which is true. Why? The question is, it's not the perforation that causes sinusitis. When you have a perforated sinus membrane, and if you place a particulate graft in there, and it gets dislodged, it will block out the ostium. Okay, when you block out the ostium gets closed. Now it becomes an anaerobic environment where the gram-negative bacteria is going to cause the infection. So what he's doing right here, he's sealing it up with a gelatin sponge, and the statement that he makes is that it holds the blood clot very well. Blood clot, not graft material, but blood clot, because the healing is that it is a blood clot that is going to start the cascade of a healing process and bone regeneration. Okay?
And the CGF membrane,
Bone graft does not turn into bone.
CGF block
It's a space maintenance
placed to
and blood
accelerate
clot.
bone regeneration in the sinus
He's only
cavity.
using a PRF gel.
No bone graft was used because it's risky. I should prevent possible post-operative sinusitis in this case, 100%. So 2 biotime implant was placed,
Hardly has any
and Santa
bone remaining.
1 was placed on
I'm surprised
second
he
molar
got the
implant,
stability.
and Santa 2 was placed on first molar.
Implant spinning.
Initial stability of implant was not strong, as shown on this video.
It was moving.
Now you can see 6 millimeter vertical defect here
Oh, good God.
and horizontal defect. Sticky tooth ROB window was repositioned to prevent soft tissue ingrowth into the sinus cavity. Collagen membrane was placed under the palatal flap. Membrane was squeezed in.
So he's not using
And
the
sticky
collagen
tooth
membrane to stabilize the graft. He's
was
using it as
placed.
a barrier, right? Because stabilization is achieved by the sticky bone itself.
Placed over the sticky tooth bone
No bone tacking, no nothing.
as a layered grafting procedure. This is the post-op before pre-op community. This is a post-op community. This is a 4 months healing. Now you can see the excellent 3-dimensional ridge augmentation and the 100% vital U-bone formation in the sinus cavity without any risk of post-operative sinusitis. This is a serial periapical radiogram before extraction.
Wow.
After extraction, this is a post-op. After 5 months, 2 weeks healing, the wound was exposed. Uncovering was done. You can see the excellent vertical bone regenerations. This is a final restoration. This is a 1 year, 6 months loading. The marginal bone is very.
But what you'll notice is that, though, all these type of surgery, Santa, using because you're releasing the tissue well over, right? You are migrating a vestibular depth more coronally. That means many of these cases will end up needing a free gingival grafting with a vestibular deepening procedure.
Very difficult case to treat, but my surgery is very simple. If you use the sticky conditioned bone and Santa, all tenting abutment for 3-dimensional ridge augmentation, your surgery also will be simple. The same patient, anterior mandible, I did ridge augmentation with the simultaneous implant augmentation before sinus augmentation. Look at the huge defect here.
That's massive.
3 biotime implant was placed. Inside
No
stability
way.
was good, but take a close look at the more than 10 millimeter vertical defect.
Oh, good Lord.
The lingual releasing incision.
Now
and
that's
releasing
extreme,
was
right?
done
That's extreme.
before implant placement. So one mini implant was placed to deliver immediate restoration for this young patient.
Just without placing Santa, how come he didn't use Santa?
Tooth bone was placed of the
I would have
implant,
imagined he
but
would
I
have used
forgot
Santa.
to place a Santa. In this case, this is immediate fixed restoration. After 5 months healing, the wound was exposed. The vertical augmentation looks good, but there is some bone resorption around implant.
Oh, he
neck.
should have used Santa.
I should have placed
I should have used a Santa.
to prevent collapse of
I love it. I love it.
to allow overgrafting. So
Oh, the secondary
bone
surgery.
grafting was done and pancho technique was done. This is before. This is final. It's not perfect, but it looks okay. This is 1 year loading. There's slight bone loss here. So I strongly recommend to use tenting abutment for vertical augmentation in order to get stable marginal bone. Here's another case using tenting abutment. This is a very severe severe cases showing vertical defect. My colleague's case.
His failing implant.
My colleague reported this patient to me, so I removed this failed implant and I did piezoelectric bacteriocidal curettage at the same time, and 2 implant was.
Professor Sohn, what component of the piezoelectric is a bactericidal? Are you using with a special solution to kill this bacteria?
At the same time with the good stability thanks to endostomy. As I mentioned before, when you do the vertical augmentation with the tenting implant, tenting abutment, the tenting implant should be placed 2 millimeters.
This is
1
important.
or 2 millimeters deeper
This
to
is a
the
great
proximal bone height. And Tanta 2 was placed to accommodate, to allow the overgrafting and to prevent the collapse of bone graft material during healing periods. The sticky tooth bone, the mixture of sticky tooth bone and bovine bone was grafted, and the collagen membrane was placed without stabilization technique, and primary wound close was done. This is pre-op, this is post-op, this is post-op. This is the convincingly after 4 months healing. You can see the excellent 3-dimensional ridge augmentations with this simple technique. So this is the final restoration after 3 months.
See that? Most of these cases has minimal attached gingiva, low vestibule, so it needs a FGG. That's why he developed the sutureless FGG procedure. It makes sense.
This is another case using Santa and stick.
Just the vibration alone. Thank you, Professor Sohn.
You can see the 6 millimeter, the vertical defect, 3-dimensional defect. So Tanta 2 was placed, and the sticky bovine, 1 piece of sticky bovine was placed around exposed implant, and collagen membrane was carved.
Thank
After
you.
3 months
Thank you,
healing,
Professor Sohn.
wound was exposed. You can see the good bone regeneration around implant. Temporary restorations. This is the final restoration after 6 months loading. You can see the this is radiogram after implant placement. You can see the excellent vertical ridge augmentation with this simple technique. Here's another case. These implants were failed, so extracted, and I placed the 2 new implant immediately after the cleaning this site.
With the piezo.
Santa 2 was placed on implant platform. Sticky bovine bone was placed, and CGF membrane was placed to accelerate wound healing. This is post-op. This is okay. After 4 months healing, wound was exposed. This is before. This is after 6 months loading. You can see the beautiful vertical ridge augmentation with this simple technique. This is a similar cases. After remove of implant, 10 weeks soft tissue healing was allowed. there is no bone to accommodate implant of the implant inferior alveolar canal. So I decided to place implant a little bit lingual to the inferior alveolar canal.
Oh, look at the 37 side.
37.
This is actually into lingual. That's ballsy.
As I mentioned before, many times do not consider complicated invasive technique for 3D dimensional ridge augmentation. So two implant was placed.
Oh, Densabur.
In this case, the under osteotomy using Densabur in reverse mode was used to save bone during osteotomy to save inferior alveolar nerve. The two implant was placed at, simultaneously, and initial stability was very good, even though this implant has only 2 millimeter apical engagement.
Wow.
Now there is the 6 millimeter vertical defect. Santa 2 was placed on each implant. You can see the complete
2
loss
millimeter
of the
collar heights.
lingual and buccal bone. This is occlusal view. Sticky bovine bone, mixture of sticky porcine and mineral allograft was grafted. Collagen membrane was placed. CGF membrane was placed over the collagen membrane to accelerate wound healing. Primary suture was done. This is before. This is post-op.
Look at how close the nerve is right here.
This is a post-op convexity. Now you can see
That's precision.
The implant positioned lingually to the alveolar canal. 5 months.
He didn't use guided surgery, guys. He did a freehand.
Good bone regeneration around
Freehand.
implant. This is final restorations. Okay. So as I mentioned before, there are many advantages of Santa.
We're almost near the
procedure.
end.
This technique simplify your ridge augmentation. No, you don't need to place a bone tag or membrane stabilization shoot. This technique prevents vertical and horizontal collapse of a bone graft during healing period. And this technique maintains the volume of a bone graft of the implant platform during healing period. So,
all right, Shada, good luck with your surgery, my friend.
Surgery using black bone
Good luck.
plate or titanium
See you
metal
tomorrow.
text, with the membrane text. It's time to think outside the box with ridge augmentation. No more invasive, old-fashioned ridge augmentation as shown on this slide. No more black bone in my practice. No more bony plate in my practice. No more tenting pole screw in my practice. No more titanium mesh in my practice when I place the implant simultaneously. No more stabilization technique for membrane. This is not easy job. My conclusion. This is my conclusion. Let's follow. Keep it smart, simple principle with the sinus ridge augmentation. Simplicity is the best option for our patient. Isaac Newton said, nature is pleased with the simplicity and nature is no dummy. Thank you very much for your kind attention.
Wow. Amazing. This was my first time watching this presentation as well. It's one of the more complete presentation by Dr. Professor Sohn, and I think we're very lucky because of the pandemic. He was to present this wonderful presentation in Iran, but he got to do that through online, and we got lucky to get this complete presentation from start to finish. And not only that, he got to join us live, which is just amazing. So Professor Sohn, thank you so much for joining, and I'll give our members this exquisite experience of watching your presentation and also get a feedback from you. So now you guys know how I do my own myself learning. This is how I learn. I don't necessarily focus on the technique so much. I mean, there's a great technique, don't get me wrong, from Professor Sohn, but fancy technique without supporting the concept of biological healing doesn't really mean much. Everything that Professor Sohn has done, his logic, why he moved away from fancy block grafting and time mesh and everything, it's not because he doesn't know how to do those, but as long as we follow the proper healing principle, biology, you can design your surgical concept and surgical protocol to optimize the outcome, right? And simplicity sometimes is the ultimate sophistication. That is Da Vinci. So, Professor Sohn, thank you so much, and you guys who stayed up till this late with me, I really appreciate it. So I'm gonna have to say, you guys enjoy the evening. Well, I didn't enjoy the bedtime, and I hope to see you guys again tomorrow. Okay, I'll try to be active and post as much as I can during the holiday season. Professor Sohn, you're a legend. I really admire you. We love you, and we're so lucky to have you as part of a Begin member. So thank you so much. Appreciate it all the time. Take care. Okay, 건강하세요. Good night.